Good evening, everyone. Welcome to today's masterclass brought to you by the Academic Council of Indian Association of Surgical Oncology. I invite our advisor, Dr. Raj Govind Sharma, to kindly deliver the welcome address on behalf of IASO today. You're muted, sir. Oh, we can't hear you, sir. One second. We were just able to hear you. I don't know what happened in between. No. We're not able to hear you, sir. Okay. Yeah. So, right. Thank you so much for your presence, sir. And I'm sure in some time your technical error will get corrected. So the topic for today is going to be urinary bladder cancer. Let me introduce the examiners on behalf of Dr. Raj Govind, sir. We have Dr. Hemant, sir, who's a senior director of urologic and gynecologic oncosurgery and head of surgical oncology at Nanavati Max Hospital, Mumbai. He was prior professor and head of Department of Surgical Oncology, Urology and Gynec Oncology at Tata Memorial Hospital, Mumbai, as well as at PD Hinduja National Hospital and Research Center, Mumbai. He has many accolades, including Dr. Pinnamaneni Venkateshwar Rao Gold Medal of Urological Society of India for outstanding contribution to the specialty of urologic oncology in India in the year 2016. We welcome you, sir, to today's webinar. He'll be joined by Dr. Anand Raja, who's an associate professor of surgical oncology at Cancer Institute, Adyar, and he specializes in urological cancers and musculoskeletal tumors. We welcome you to Dr. Anand Raja. They'll be joined by our examinees today, who will be Dr. Archana, who's a resident in the Department of Surgical Oncology at Chipmar, and Dr. Avinash Tale, who is a resident in the Department of Surgical Oncology at TMH, Mumbai. Few instructions for the upcoming session. The first 1 hour of the session is going to be a mock examination. So to the examinees, we request you to give to-the-point answers to the questions being asked. It's not expected that you know everything. So please mention that you don't know something and it can't be passed to the other examinee, and it will save us time. Please catch the hints that the examiners keep giving, because that is a practice that you need to develop for your coming exams as well. For our moderator, Dr. Raja, we request you to please address the examinees by their name when you're asking a question. This helps us to avoid confusion as to who is supposed to answer. And the second request would be to please ensure that both of them get equal opportunity to contribute. To our examiners, both of them, in interest of the online viewers, both who are live today, as well as viewers who are viewing it on YouTube later. Unlike an exam, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. We see a few senior IASO members in the participants list. We thank you for taking time out to join us, and we request you to post in your inputs in the chat box as well. They're highly appreciated. And for the residents, it's a unique opportunity to clear all your doubts regarding this subject. We hope you make full up. As for the timekeeping, at 30 minutes and 45 minutes, I'll be reminding our moderator, Dr. Raja, via a text. With that, I'll stop my screen share and invite our moderator, Dr. Raja, to kindly take the proceedings forward for the first half of this webinar.
Thank you so much, Srijan. And without much further ado, I think all the examiners, all the moderators, the students have all been, introduced. So I hope everyone can see my slides, and let me go full screen on that. So can everyone see my slide, and is everything visible? Hello, can everyone see my slide?
Yes, it's visible.
Right. Going to the welcome everyone, welcome all the students. So the first case, we have a set of 3 cases. The first case is a 70-year-old gentleman who was a hypertensive smoker, evaluated for hematuria of 6 months duration elsewhere. A CT scan done outside at that time was suggestive of a 4.4 into 2.9 centimeter lesion over the left lateral wall of the bladder, involving the uretrovesical junction with grade 2 hydrouretronephrosis. He was advised TURBT but did not take treatment, defaulted for 6 months, and then presented to our institute. Avinash, looking at all of this, what are the next steps? What are the things that come into your mind? He's a hypertensive smoker, and the CT scan is what it is.
Yes.
So what are the next steps that you keep thinking about?
Yeah, so looking at the history, sir, 70-year-old gentleman with strong history of smoking and hypertension with a gross hematuria of 6 month duration, I would look more likely think in terms of malignancy, because
Right.
yeah. So I would, and patient has already been imaged previously and he has defaulted. So I would like to take complete history and examine and then proceed further for the investigation.
What complete history are you talking about? Any relevant history?
Sir, any other history of any irritative bladder symptoms apart from hematuria, and hematuria ka complete history, whether how much is the severity of hematuria, whether the hematuria is the severity associated pain, any passage of clots, and any associated symptoms and pain along with the hematuria, and any other symptoms like cough, hemoptysis, backache, or any other symptoms which will suggest advanced disease.
So there is only hematuria. There are no other symptoms suggestive of metastatic disease, no other symptoms that are suggestive of anything else. There is no pain. So what is the typical pattern of hematuria in patients with bladder cancer?
So it will be a gross total hematuria, and it might be associated with passage of clots if it is severe, and
intermittent gross hematuria, which is with clots. What is the one word that you are missing that I'm looking for?
Painless hematuria.
Painless.
Very good. It's painless. Excellent. So he's a smoker. So any thoughts on smokers? What is the risk of patients who smoke and risk of bladder cancer? Ever smokers, non-smokers? I put the list of questions out there. If you could just give some numbers to this, it'll be very helpful for everyone. Smoking, as we all know, is the biggest etiological factor for bladder cancer. So could you put some numbers to this? So the questions are already up.
So smoking,
Avinash,
yes, smoking is strong risk factor associated with bladder cancer. However, I'm not sure with the numbers, but it is strongly associated risk factor for development of bladder cancer.
Yeah, so that's at an MBBS level. You can say MBBS or MS level. You can say that smoking is associated with bladder cancer.
Yes,
but
sir.
When you come to an MCH level, you should know some numbers because that makes a lot of difference. Archana, any thoughts on this?
So among bladder cancer, nearly 30 to 50% is contributed by smoking, but how much the risk I'm not sure.
Yeah, so you should get some numbers to this. So ever smokers compared to never smokers, the relative risk is about 4. It's slightly more it's about 4.1 to 4.2 for about males. It's a slightly less around the 4 mark, 3.8 to 3.6 for about women. If you see patients who cease smoking, even 10 years after that, the risk never goes down to baseline. The relative risk is about 2.5. Severity of smoking, the people who smoke more than 20 or 30 pack years are associated with higher grade tumors and higher stage tumors. And as far as secondhand smoke is concerned, that's also a very important factor because it has also been seen that patients who are exposed to smoking earlier in their lifetime with 2 or more smokers in the family during childhood, had 3 to 5-fold increased risk of bladder cancer compared to people without childhood smoke. And the risk was about 2 times if their partner were a severe smoker. So exposure to secondhand smoke at a younger date had higher risk. Any ideas about, okay, we can leave opium and cannabis, anything about hair dyes, occupational? We keep talking about, you should drink more water. How much drinking water or less water, fluid intake, is there an increase or decreased risk of bladder cancer?
So occupational exposure, the people who are working in leather industries who have exposure to aromatic amines and gas and tar manufacturing company have high risk of development of bladder cancer. And along with the fluid intake, it is said that having a less fluid intake along with chlorinated water also.
No. How less? Like I said, at an MBBS and MS level, you can say more and less, but at MCH level, you should know how much more, how much less. Archana, any thoughts on this?
So hair dyes has occupation, like you said, leather industry, paint workers.
That's fine. That's done. Fluid intake and chlorination.
Fluid intake, I think in a study, there is no relationship between fluid intake and bladder cancer.
No. It's been seen that if you take fluid intake more than 2.5 liters a day compared to less than or equal to 1.3 liters in a day, there is the health professional follow-up study that had almost 50,000 participants over a 10-year period. The relative risk was 0.5 for people who took more than 2.5 liters. So if you drink 2.5 to 3 liters of fluid every day, because all the the toxins that come in and get implanted into bladder, that get washed away. So the relative risk was half if you drank more water compared to less water. And chlorination again is something that happens every day in our own country. A lot of the piped water that you get is chlorinated. So anything about chlorination and risk of bladder cancer? Is it good? Is it bad? You should do it. You should not do it. Okay, Archana, Avinash, any one of you can take it. Okay, the relative risk is about 1.2 to 1.4 if you chlorinate water. And any idea on why chlorination causes increased risk of bladder cancer? Again, I've just taken this fluid and chlorination because this is something that happens every day in our country. So basically what happens is when you chlorinate the water, it turns into ozone, and then this ozonation leads to the formation of THMs, which is trihalomethanes, and that is the byproduct that causes bladder cancer. Hemant sir, anything else that you want to take up?
I think that's all right. I think the only thing is now, of course, it's not very commonly seen in our country, but the water which has traces of arsenic also in both countries, again, the bladder cancer is much higher.
So there's this thing about increased risk of hair dyes and bladder cancer. So most people in India nowadays dye their hair. People actually come up to the OP clinic and say, sir, we've read that dyeing our hair causes bladder cancer. So will a person who periodically dyes his or her hair, will they get bladder cancer? Any idea about this? And again, I'm asking this because this is a very common scenario which a lot of people will come and ask you.
So hair dyes, they have done multiple studies which has not shown any great association with development of bladder cancer. But however,
so I think you've gone the complete opposite way. Hair dyes have an increased risk of bladder cancer, but the risk is for people who are constantly working with hair dyes. If people are there with high exposure to hair dyes, which they're using on a very regular basis, and they are hairdressers and they've been exposed for more than 10 years or so, that's when the risk of bladder cancer increases. But for sporadic users who color their hair once in a couple of months, there is absolutely no increased risk. So the risk is for the workers and not for the consumers. Okay, so this is what was done. And the patient, so this was the CT scan, and then the patient comes to you. So what next? How will you evaluate this patient further?
So I will do a complete routine blood investigation along with renal function test and creatinine and a urine cytology.
So
and
the creatinine is part of RFT. So do you want to say?
No, sir. I will do a complete all routine investigation, which will include a renal function test with renal function test.
Okay. Anything else? That's normal.
Yes.
That's normal.
Okay, I would like to do a urine cytology and a cross-sectional imaging in form of CT abdomen pelvis with intravenous urography.
So this is what was done.
Urine cytology. What
Yes.
is the accuracy? What is the sensitivity of urine
Yes.
cytology?
So urine cytology has very low sensitivity in case of low-grade urothelial cancer, less than 16%. However, it predicts a high-grade urothelial malignancy in more than 86%. And it can suggest presence of CIS also, carcinoma in situ.
What else?
What's up?
What else? I said if there is a bladder tumor, okay, and which is low grade, and you get cytology positive, what does that suggest?
More likely suggest about carcinoma in situ, sir.
Or
High-grade malignancy.
no,
Oh, no,
yes. But what else? Where else would you look for disease then?
Upper urethral.
Correct. So
Yeah.
you look at the upper urinary tracts as well as the prostatic urethra.
Yes.
could you give me some number on how sensitive the urine cytology is? Some random number that you can think of?
So in the urine cytology positive is more than 86%.
No, the sensitivity. The overall sensitivity is about 35%. For grade 1 and grade 2 is slightly lesser. For grade 2 is about 65. For grade 3 is about 65%. So these the routine investigations were done normal. Urine cytology was negative. The CT scan is showing exactly what it showed before. No progression. The chest X-ray was normal. What next?
So looking at this investigation, I would like to go ahead with transurethral resection of bladder tumor, TURBT, to see the T stage and stage the disease accordingly. That is stratify the disease.
So the TURBT was done, and that's so that there is a solitary tumor in the bladder. The intraoperative, the ureteric orifice was stenosed. Will you use stenting? Is it warranted or not? And what is the role for doing what is enhanced cystoscopy? And what is enhanced cystoscopy? When will you use it? And what are the components of transurethral resection of bladder tumor? Hemant sir, anything else based on the operative findings?
Sure. Tell me, what are the essential elements of a transurethral resection of bladder tumor?
Look at the number site associated with the carcinoma in situ, sir. And during resection, we have to include the muscle layer also. And if it is near the ureteric orifice, better to use a cutting current to avoid stenosis of the ureteric orifice further. And post
stenos because of the disease, would you stent it or will not stent it?
I think they have to stent the lesion.
The evidence about this is controversial. There are some people who feel that if you stent, you'll be sending the malignant cells up into the urinary tract. But at the same time, if you feel that this patient has likely to have a non-muscle invasive cancer, then it's always better to stent these things so that there is no stenosis of the urinary orifice. Okay?
Dr. Archana, you said CIS. So on conventional cystoscopy, when you're doing a TURBT, can you identify CIS like that?
Carcinoma in situ, with the enhanced cystoscopy, the detection of carcinoma in situ is better. But in conventional cystoscopy, whiteley cystoscopy also you can visualize.
You can visualize cystos.
Reddish areas. It is better visualized with the enhanced cystoscopy, including narrowband imaging and HL enhanced cystoscopy.
What is fluorescent cystoscopy?
HL will be administered and then it will be visualized under blue light, and carcinoma in situ areas will be visualized as with reddish glow.
So basically, it is a photodynamic cystoscopy. Okay. With a blue light or a purple light, you can use either. And the second is a narrowband imaging. So apart from identifying carcinoma in situ, do you think there is any clinical efficacy of doing this cystoscopy using enhanced cystoscopy at the time of TUR?
In narrowband imaging, it is noted that in low-grade lesions, the recurrence is reduced. But otherwise, there is no difference in the occurrence rate between white light and narrowband imaging technique.
How much is the reduction in the recurrence rate? Does it also cause reduction in the progression to muscle invasion?
Yes, I think nearly 5% or something.
More than that. It is almost about 15-20% reduction in the recurrence rate if you use one of these enhanced cystoscopic approaches. But there is no difference in progression to muscle invasion or the need for cystectomy. Okay? So it definitely, both the short and the long-term recurrences are reduced if you use this.
Yes.
Dr. Archana, well answered. Any role for, just to complete the topic here, any role for use of enhanced cystoscopy during follow-up?
There is no established role for enhanced cystoscopy in diagnosis or surveillance. Only if we are following up for BCG or in presence of carcinoma in situ.
Patient is completed treatment. So the patient is completed treatment on regular follow-up. Is there any role for enhanced cystoscopy during surveillance cystoscopy?
There is no role in surveillance cystoscopy according to AAO guidelines.
Correct. Excellent.
At the time of TUR, will you do some random biopsies from the bladder or the prostatic urethra?
In low-grade lesions, the chance of
you don't have the histology with you, do you?
If suspicious areas are there, then bladder is random.
Suspicious, yes, but I'm talking about non-suspicious, normal-looking areas.
So if urine cytology is positive without,
correct.
Yeah. And in cases of bladder neck tumor, I would like to even biopsy the prostatic urethra. And in cases of presence of CIS, I would like to do a random biopsies also.
Yeah. Especially if there is a CIS or if there is a tumor in the bladder neck or a prostatic urethra, then you should do a prostatic urethral biopsy also. Right.
So the biopsy was, the TURBT was done, and this is what was the biopsy report. So the papillary urothelial carcinoma, low grade, the size was 4.5 centimeters with focal invasion into the lamina propria. The deep muscle and the bladder neck were free. So what next? What is the risk stratification for this patient? What are the next lines of treatment for this patient?
It's a T1 low-grade lesion, sir, but it is more than 3 centimeters, so it's a high-risk lesion according to EUA guideline.
Excellent, Archana. So the patient has got a high-risk lesion. So when you say risk, low risk, intermediate risk, and high risk, what do you mean by risk?
The risk of recurrence and progression.
Is it risk of recurrence only or progression only, or is it both?
Both.
Right. And could you give us a number for risk of progression or risk of recurrence in high-grade non-muscle invasive bladder cancer?
In high grade, the risk of recurrence is 50% and progression is 80%. In low
So
grade,
whenever you say risk of recurrence or progression, risk is always correlated to time. So risk of 50% in over a period of dash. So these are some things that you should be very careful of, because whenever you quantify risk, quantification of risk is always correlated with time. 20% risk in 5 years time, 20% risk in 10 years time, or 20% risk in 1 year time. That makes a huge difference to to everything that we talk about. So you should be very careful of that. So will you do a re-TURBT, Dr. Hemant sir? These questions are next. Why would you want to do a re-TURBT? What yes, what not? What's the rationale to do it?
Would you like to do a re-TURBT or a second TURBT here? Re-resection?
it's a high risk tumor. I think we have to do a re-TURBT within 4 to 6 weeks.
Yeah. So what are the indications? When we say a high risk tumor, in which patients, when you get the histology, would you do a re-TUR?
Previous incomplete resection.
Correct.
Then it is seen that there is a chances of 20 to 40% upstaging if the previous TURBT does not show any muscle this, and so the re-TURBT is warranted, which will upstage the disease.
So will you do it only when there is no, when you don't see muscle in the TURBT specimen, or you do it even when you see the muscle?
So I would like to see for on the pathology report the stage, grade, presence of CIS, any presence of detrusor muscle, and I would like to see the completeness of resection, whether the initial resection was complete or no.
I'm not talking about TURBT. I'm just saying, I said whenever you are thinking of a re-resection or a re-TUR, what are your indications? If you see that the pathology report says deep muscle free, that means deep muscle has been seen and
Yes.
is found to be free. Would you do a re-TUR or will not do it?
It's a high-grade T1 lesion. I
So
think
irrespective of whether there is muscles free or not, you will still go ahead and do a re-TUR. Correct? Because there are other high-risk factors. Now, whenever you see a muscle in the specimen, that muscle need not be the muscle which was directly under that tumor. It may be from some other place. So even when there is muscle seen and muscle is free, even then about 40% of these patients will have a residual tumor at second TUR. Okay. So for all high-grade lesions, for all T1 lesions, and when incomplete resection is considered, then all these patients must have a second TUR. Okay, irrespective of whether there is muscle seen or not seen in the first TUR. Okay. Yeah. And when will you do a re-resection, if at all you have to do it?
4 to 6 weeks after initial TURBT.
Correct. That will allow the resected part to heal, and you can identify between inflammation and cancer. All right. So, do you use any specific risk stratification tool? Are you aware of any of these tools?
So there's EORTC risk classification.
Correct. So that is the most commonly used one, right? EORTC risk stratification. Okay. Or you can use the European Association of Urology.
Yes.
So tell me, why is this risk stratification done? One is for prognosis. What else?
the treatment and the surveillance also depends on the risk stratification.
Now, at the time of TUR, will you do something else?
We have to do a manual.
Bimanual examination also.
Bimanual examination, yes, very important. What else? We're talking about intravesical therapy here, aren't we?
Yes, sir.
So any intravesical therapy you will get at the time of TUR.
Intravesical chemotherapy can be given within 6 hours.
Can be given or should be given?
Be given in
Dr. Archana, please be careful when you say intravesical therapy. Is it chemotherapy? Is it immunotherapy? Is it BCG? So we'll come to that later. Once you commit to say that it's chemotherapy, then I think the Viva goes off on a completely different tangent. So, be very careful of every word that you say. Yeah. Sir, sorry to interrupt you, sir. Please.
What intravesical therapy will you use in the immediate postoperative period?
So mitomycin C can be used.
Can be used, but
No, mitomycin C is used, sorry.
Will you do it in all patients?
So I would like to see how was the TURBT, whether it was very deep, whether there was any presence of any hematuria or any risk of perforation. I would like to assess this, and then I would like to go ahead with intravesical chemotherapy.
Correct. So if there is hemorrhage or a perceived risk of perforation, then you will not do intravesical chemotherapy.
Yes.
It's a single installation post-operative chemotherapy installation. Okay, single installation.
Yes.
Now, as you rightly said, you can use mitomycin, you can use doxorubicin, you can use epirubicin, all are equally effective. In fact, there are some trials now which just use water, distilled water, or your normal saline, and they have shown a similar effect. How much is the reduction in the recurrence rate by this single installation?
The 5-year recurrence rates have decreased by 14%, sir.
In which tumors?
The intermediate risk tumor.
Basically, low and low intermediate risk. In high intermediate risk and high risk patients, there is no effect of this single installation. Okay, but you don't know what is the histology, so your ideally should be done in all patients.
Yes.
Okay, fair. Now, how do you decide about intravesical therapy? Avinash?
Yes, sir. So according to risk stratification, tumor comes into a high-grade tumor,
High
high risk.
high
Yes,
risk.
sir.
Yes,
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 sir.
yes.
So I would like.
How many risk groups are there?
So there are 4 risk group according to WHO, and AU has 3, sir: low, intermediate, and high. And high has another classification which is very high risk.
Very high. Even institution has the same.
Yes.
Okay. Okay. So then what will you do for low risk patients?
So low risk patient, I would like to give one post URBT single installation of intravesical chemotherapy, and I would like to observe the patient,
And you would like to?
observe and keep the patient on follow-up, sir.
So when will you do the first cystoscopy?
So first cystoscopy will be done at 3 monthly.
And if that's normal, then subsequently?
Supplement annually, sir.
9 months, at 9 months.
Yes.
Okay, yeah.
And if it is
intermediate risk patient, what will you do?
it's an intermediate risk patient, I would like to give a single agent intravesical chemotherapy, followed by following 2 to 6 weeks, I would like to give an intravesical BCG, which will be induction dose 6 weekly and up to 1 year maintenance dose, sir.
Why not mitomycin?
So
Mitomycin and BCG both can be used. Now, decide.
Some multiple meta-analysis and studies have shown that BCG has reduced the recurrence rate and progression in this. So BCG should be considered as a first line for this.
You can definitely use mitomycin also. So how do you decide? In patients where the EORTC score is less than 5 and when the recurrence rate is less than 1, less than 2, that's maximum 1 per year, then you can use mitomycin. Whenever the EORTC score is more than 5, you have to use BCG. Okay. That's how you classify them into low intermediate risk and high intermediate risk.
Yes.
Okay, so in low intermediate risk, whether you use BCG or mitomycin does not make a difference. Okay. And mitomycin also you will use maintenance or you will not use maintenance?
Not use maintenance.
You should use maintenance again, once a month for a year.
Okay.
When you give BCG, you also need to give mitomycin for a year.
Okay.
And when you give mitomycin, are there any specific ways? Is there a specific way in which you do? You give mitomycin intravesical?
So it will be given in 40 mg and 500 ml of water to make
500 ml. 500 ml.
No, sir. It will be given in more. The urine should be Sorry, sir.
What is optimized mitomycin installation?
So it will be given in a more concentrated dose.
Yes. So 40 milligram in 20 ml.
Yes, sir. Sorry.
Distilled water. Then the installation time is at least 1 hour.
1 hour.
Okay. And then you also do pH modifications.
Yes. You will make more urine more alkaline to have a more effect.
Yes. And the randomized trials have shown that there's a significant benefit of doing this optimized mitomycin. What about those devices?
So there are multiple devices like HiVec.
Yeah. So do you think they're useful?
So not really sure, but studies have shown they are useful in.
No, in the primary setting, there is no additional benefit of using either the microwave or HiVec or whatever. Okay, only in the recurrent setting it is supposed to have some benefit.
Okay.
Fine.
Dr. Archana, how does mitomycin act intravesically? When you give a single dose of post-surgery mitomycin C, how does it work? What's the mechanism of action?
That's on the residual tumor cells.
Pardon?
That's on the residual tumor cells.
So if you have, say, a solitary tumor or 2 sites of tumor, and then suppose you have 20 sites of tumor, will you give mitomycin in both cases, or will you give one or the other, or irrespective of the number or size of the lesions, you'll give intravesical mitomycin C?
I feel irrespective of number we should give. If the carcinoma is there, it's a high grade lesion, high risk.
That's what sir was asking you. It's the benefit of mitomycin C was there in the lower risk patients, not so much in the high risk patients. Why do you think that happened?
Not sure.
Yeah, so when you have a high risk patients, to say that if you had multiple tumors, or if you had to say that there was more carcinoma in situ, if there was extensive disease, we know that urothelial cancers are field cancerization. So if you already have multiple sites of carcinoma in situ, if you already have multiple sites of tumor, so the field cancerization that has already happened at all sites. So the tumor cells that are shed at the time of cystoscopy intravesically that you are trying to kill, the benefit may be in lower risk patients where the field cancerization has probably not happened, or there are oligo one or two sites of tumor. If the bladder is studded, then there might not be an additional role of giving mitomycin. That's what sir was also referring to when he said that the high risk patients, the benefit was more in the low and the in the intermediate risk patients. Fine. So then subsequently, we did a check cystoscopy where there was multiple superficial bladders all over, everywhere inside the bladder, everywhere, and the patient underwent a re-TURBT, and the biopsy again was a papillary urothelial carcinoma, low grade with invasion of lamina propria. Muscles were free. However, because he was high risk initially, because the size was tumor was more, we gave him BCG. So this is the protocol that we follow in our institute, and we published it as well. 6 cycles of weekly and for reassessment, and then 6 cycles of monthly BCG. However, some thoughts on how does BCG act, what are the doses of BCG, some maintenance schedules, what is the efficacy of BCG and complications. So I put the questions out there. Maybe we can start with Archana, who's been quiet for a while, and then we can go on to Avinash.
BCG binds to fibroactin inside bladder, and it increases the influx of cytokines, interferons. It increases the T helper type 1 immune response.
Fine.
Especially
good.
Gamma interleukin 2, interleukin 12.
Yeah, fine. What about the dose? What is the one thing that you did not say in mechanism of action? Induction of CD4 counts and macrophages. So that's very, very, very important. And interferon gamma. So these are two, in addition to all the cytokines that you said, increased expression of interferon gamma and induction of CD4 T cells and macrophages is so one of the important factors here. Fine. In the interest of going on, what dose of BCG do we usually give? What is the dose of BCG in one vial, and how many vials do we give routinely? Avinash?
So it's 40 mg, 2 vials we give. We give generally 80 mg.
Any other dose that you know
of? 120.
What about 40 milligram?
Yes, sir, 40 also.
So from your own institute, there's a very seminal paper on, I would request, I think it's out of the scope of this discussion right here, right now, but there's a wonderful paper that has come out from the Tata Hospital, where Dr. Gagan has written about, BCG dose, and especially it's a review paper on dose of BCG, what needs to be given, what does not need to be given, how is the dose of BCG calculated, so on and so forth. It's published in the Indian Journal of Urology, is available for open access, free access. I'd request everybody to go and read it. The dose of BCG is usually between 80 and 120. 40 is clearly inferior. 80 and 120 is what usually is given. 120 might be better than 80, but tolerance issues are there. Our own paper on abbreviated dose of BCG, we found that even though we gave 120, most of our patients tolerated BCG very well, and most of them completed treatment. But that's not the standard of care that is published across the world. So do you know something about who was LAM? What is LAM's protocol? And what is the maintenance schedule of BCG? Any other abbreviated schedules of BCG that you know of? Archana.
For intermediate risk patients, 1 year maintenance schedule. High risk
First, what is LAM's protocol?
LAMs give an induction dose. So LAM give an induction dose at once a week for 6 weeks, and maintenance dose is once a week for 3 weeks, at 3 months, 6 months, and every 6 monthly for 3 years.
Correct. So that is the landmark study. So what was the benefit from LAM's paper? And could you quantify the benefit of Lamb's of Lamb's paper? And what was the benefit in terms of recurrence, in terms
The
of
Lamb's paper was studied in SOG trial, which showed the recurrence-free survival of 76 months in the maintenance arm versus 35 months in the only control arm, and the 5-year overall survival 83% versus 78%. So
excellent?
At
Uh,
what period of time?
the 5 years,
At 10 years. We have a 10-year data available from that paper. At 10
Yeah.
years, how much is the difference?
10 years, I'm not sure.
The recurrence rate from 52% has come down to 25%. Okay. And the PFS has increased from 36 to 48 months.
Okay, sir.
Okay. Yeah. So even at 10 years, the benefit still remains.
Yeah.
Okay.
Right. Any complications of BCG that you are aware of? So if you had to give a number to this, again, I'm just putting it out there. So if you get a case specifically like this, some examiners might tend to ask you, what is the benefit of BCG in terms of preventing grade progression, in terms of preventing stage progression. So these are some numbers that you should have at your fingertips like that. The effect of BCG on preventing grade progression is this, or preventing stage progression is this. So these are some numbers that you should know at the back of your hand. Complications, Archana?
BCG toxicity can occur.
Is there a named criteria for BCG toxicity? How do you quantify? Is there a named classification for that?
There are 3 grades of toxicity: mild, moderate, and severe.
No. Is there a named way in which is there a name for that? Anyway, you can read it up. Fine.
It's Clevin. Sorry.
Yeah, please go ahead, Avinash.
So I'm not sure. It's Clevin something. So I'm not sure complete class.
No.
Not
No.
Clevin, sir.
It's all right. Please.
Basically, there are various institutions who have their own this thing. So Cleveland Clinic classification.
In Cleveland, so yes, sorry.
Yeah, the Cleveland Clinic classification is usually one that most people follow, but there are other classification systems as well.
Yes.
Yes. How do you quantify or qualify complications? Archana, you were saying something.
Having low-grade fever, burning maturation, pain less than 48 hours, it is low grade. If it is more than 48 hours, or if the symptoms are the more severe symptoms within the first 48 hours, we call it moderate. And severe symptoms including hemodynamic instability, hematuria, high-grade fever, everything quantifies as high-grade severe complications.
So is there a systemic toxicity in addition to local toxicity, and how do you avoid systemic toxicity while giving BCG?
Yes, few studies say that isoniazid can be co-administered to avoid systemic toxicity.
No, that's fine. But in what patients will you not give BCG to avoid systemic toxicity is what I'm asking you.
Patients with hematuria or previous BCG sepsis.
Previous BCG sepsis plus minus hematuria. Yeah. What hematuria? Persistent gross hematuria. Fine. What else?
Traumatic catheterization, immunocompromised patient, the patient who had previous history of the relative will be previous history of liver disease or any tuberculosis, and immunocompromised patient.
That will be there in most patients in India. Previous history. Active cystitis. Okay. So these are the patients that are at greatest risk for systemic toxicity with BCG. What is BCGiosis? Last question on this BCG question, systemic toxicity. What is BCGiosis? And patients with, most patients with bladder cancer are elderly. What's the median age of presentation for bladder cancer in India or anywhere in the world for that matter? Males differently, females differently? Archana, you can go, and then Avinash, maybe you can go. What's the median age of presentation?
Most common in males, more than 60 years.
60 or 65? Fine. So these are all elderly patients with prosthetic devices, and some of them will have cardiac pacemaker. pacemakers, and so on and so forth? Anything to do with BCG and prosthetic devices, anything like that? Do you have any idea? Any idea on that? Pacemaker or artificial valves or any orthopedic implants? So they say that people who have these, they again have increased risk of toxicity, but it's not an absolute contraindication, and you have to be more careful with all of them. That's it. They have a slightly increased risk of infective endocarditis, so on and so forth, but the data is really not that very mature. Fine. So 2 years down the line, the patient got this. We re-imaged the patient, was complaining of some bladder symptoms, got this. We did a biopsy, did a re-TUR, and again turned out to be non-muscle invasive bladder cancer. And now, if you have to define, this patient is failed BCG. So any definition of BCG failure, so these are the 4 accepted definitions of BCG failure: unresponsive, refractory, relapsing, and intolerant. Could you define what they are? Anyone? Avinash, maybe you can go in first.
Yes, sir. BCG refractory is defined as presence of T1 or high-grade tumor at the 3 months after BCG maintenance, or the TA or high-grade tumor.
No. Persistence at progression. See, these are all new definitions of BCG failure that are there. I would again request all of you to go and read up. There's a wonderful article by Dr. Ashish Kamath from MD Anderson. There was the older definitions, and then there are these newer definitions of what is refractory, relapsing, intolerance, and unresponsive. These are very, very, very important. So when you say persistent disease, it is persistence at 6 months despite adequate BCG treatment. And if you say progression, it is progression at 3 months. Yes. All right. I just put up the numbers here. Any idea about what is relapsing despite BCG treatment, Archana?
So it's recurrent high-grade tumor after completion of BCG maintenance.
So it's defined as recurrence of high-grade disease after achieving disease state at 6 months after adequate BCG, not after 1 year. This is previously been subdivided based on time to less than 12 months, 1 to 2 years, or more than 2 years. But for the purpose of being included into this category, the patient should have been disease-free at 6 months if you have a recurrence called as relapsing. All right, same for intolerant and unresponsive. I'd request urge all of you to go and read up these definitions. Will surely be asked in the exam. Hemant sir, any thoughts on this?
Yeah, I think so. Basically, now the term unresponsive is newly been introduced, and that includes the refractory and the early relapsing cases.
Yes.
Basically, there is just a category which has been added. So you need to treat refractory and early relapsing as unresponsive, and the second category is the late relapsing patient. So basically, there are 2 different categories that we really need to look at.
Right. So just to complete this case, the urine cytology was positive. The impression was a recurrent non-metastatic carcinoma bladder post TURBT and intracycle BCG. Patient underwent translethal resection. Because it was more than 2 years after the BCG was given, the patient was re-challenged with BCG. Okay, coming on to case 2. Srijan, how far away are we from finishing 45 minutes?
We are roughly at 40 minutes, sir, but I think you can have another 20 minutes.
Fine. So let's try to finish case 2 quickly. So case 2, the initial portion we've already dispensed with in case 1. So this was a 55-year-old lady evaluated for lower abdominal pain of about 4 months duration. The CT scan had showed an irregular wall thickening with a mass formation in the posterior, right lateral, and superior wall of the bladder. That was the size. It was infiltrating the right VUJ, causing hydroureteronephrosis. So that's what the CT scan looked like. You can see that there's a tumor in the bladder, filling almost the entire bladder. It's infiltrating the uterus and the vagina also. So routine investigations were done. So what next? There was some hydroureteronephrosis here, which is not seen on the scans. The RFT were normal. Would you like to do an EGFR for every patient, Avinash?
So if the creatinine and renal function tests are normal, so
Now, this is muscle invasive bladder cancer. You might potentially go on to give cisplatin.
Yes, sir. I would like to do a EGFR with
Why?
creatinine.
Why? Or a creatinine clearance, EGFR or a creatinine clearance? Why would you want to do that?
Because in muscle invasive bladder cancer, the main, if you are considering a neoadjuvant treatment therapy, the drug mainly is used is cisplatin. So, which for cisplatin eligibility, creatinine clearance or EGFR has to be more than 60 and with performance status.
Do you
So,
know what is the name of the criteria that for cisplatin eligible, ineligible?
not really.
Archana, do you know that?
So, but the creatinine level should be less than 1.8 and creatinine clearance should be more than 60.
Right. So the urine cytology was positive. The urine culture again showed some bugs. Staging investigations and treatment options. What next will you do here? So the patient had right hydroureter nephrosis. The creatinine clearance was about 55, something was there. The EGFR, RFTs were normal. What next?
Need a cystoscopy and biopsy. Need a biopsy for.
Anything else? So would you like to do a right-sided? Would you like to do a right-sided PCN? So these are the two questions that come up immediately. The patient has got a hydroureter nephrosis. Would you like to protect the kidney? Do of a PCN in all cases? Is a TURBT needed or is a cystoscopy and biopsy sufficient? Your thoughts on this, Archana?
If the creatinine clearance is normal and the creatinine and the EGFR is normal, I think depending on the grade of hydronephrosis, we can read.
So is there a grade for hydronephrosis and how you grade it? Mild, moderate, severe? So there was quite a lot of hydronephrosis. So would you, even though the RFTs are normal, would you still go and like to go instead? Hemant sir, your thoughts on this? Maybe you can clarify this for the students.
Well, what I would probably do is if the EGFR is okay and creatinine clearance is more than 50, I won't even go for 60. Then I usually don't do a percutaneous nephrostomy.
Right.
When it is really low, less than 50, then I would do a PCN, wait for the kidney function to recover a little bit, and then go ahead and give the right treatment.
Yeah, we did a PCN for her because the creat clearance was about 55 and she was a little elderly lady, did not want to risk it. So that's what we did. Again, is a TURBT needed, Avinash, in all cases, or is a cystoscopy biopsy sufficient?
TURBT is not needed in all the cases. Cystoscopy and biopsy would be sufficient.
Yeah, when there is unequivocal presence of extravesical disease, a cystoscopy and biopsy should be more than sufficient. So the patient got 3 cycles of. So when you give neoadjuvant chemotherapy, you got 3 cycles. Okay, I'll come to that later. 3 cycles of gemcitabine cisplatin, developed some toxicity after 3 cycles, had poor tolerance, and then was planned for surgery. The questions that needed are: what is the rationale for neoadjuvant chemotherapy regimes? Maybe alternate questions. Avinash and Archana, you can keep taking alternate questions quickly in the interest of time. Starting with Avinash. What's the rationale for neoadjuvant chemotherapy?
So many meta-analysis and trial has shown there is an increase in the range improvement of survival rate.
How much?
8%, so 8 to 10%.
5% increase in overall survival. What is the study?
So NORDAC 1 and NORDAC 2.
Something better than that meta-analysis?
BA06.
Nothing. ABC. Do you know of ABC meta-analysis?
Advanced bladder cancer, 5%.
Yes, there's a 5% increase in overall survival benefit. One of the largest meta-analysis was the ABC meta-analysis. What regimes do you know of, Archana?
MVAC, dose-dense MVAC, gemcitabine cisplatin.
For which regimens do you have level 1 evidence?
For gemcitabine cisplatin, we don't have a level 1 evidence. Sir. For MVAC, we have. In recent Vesper trial, DD-MVAC is found to be better compared to gemcitabine cisplatin.
Excellent. So you've answered the question after that. Dose-dense MVAC, what was the Vesper trial and what was the benefit of the dose-dense MVAC? Was it OS or was it DFS and how much was it?
One was the pathological response, which was 40 versus 20%. One was T3, less than T3 post-op histopathology. That was also improved in DD-MVAC, and one was progression-free survival. in 56 versus 25.
Excellent. So that was the result of the Vesper trial. Suppose the patient is cisplatin ineligible. Can you give carboplatin instead of cisplatin?
In metastatic setting, actually, carboplatin is
No, not metastatic. In this case, non-metastatic muscle invasive bladder cancer.
Carboplatin is inferior to cisplatin.
You can give, you cannot give. One medical oncologist will come and tell you, I'm going to give carboplatin, patient is cisplatin ineligible, I'm going to give carboplatin. Will you agree? You will not agree. Or will you say that, okay, you give carboplatin, or will you say that, no, I'll take up the patient for upfront cystectomy? Avinash?
So not sure.
Okay, so carboplatin is routinely being found inferior to cisplatin. There is more than enough data to say that carboplatin does not work. So if you cannot do cisplatin and the patient, there is no point in giving carboplatin. The whole reason why all the immunotherapy in bladder cancer came about, because you did not have anything that you could offer for the cisplatin ineligible. So do not substitute carboplatin for cisplatin. If you cannot give cisplatin, either give immunotherapy. If the patient can't afford it, then go for direct cystectomy. Cisplatin ineligible, what are the options of treatment and any evidence for that? Quickly, Avinash, I think it's your turn.
Pure 01 trial for pembrolizumab is neoadjuvant.
Excellent. So Pure 01 trial is there for pembrolizumab. What was the result of the trial?
The
Any idea?
rate 3 months, I think, is 41%.
Excellent. And I think, Archana, the next question is to you as well. Any thoughts on time delay between diagnosis and definitive therapy? You gave toxicity. We operated after 3 cycles. Could I have said, no, you wait for the toxicity to resolve and then you give 1 more cycle of chemotherapy. I'll operate only after the 4th cycle. Something so on and so forth, where I'm delaying the definitive treatment. So any thoughts between time delay and between diagnosis and definitive treatment, that is cystectomy, and any difference in outcomes?
12 weeks is the cutoff. So within 12 weeks, we have to try to operate.
Right. There are a lot of studies, anywhere between 12 to 14 weeks, 10 to 14 week studies are there, but the cutoff is at, most people would agree that the cutoff is at 12 weeks. If you should operate within 12 weeks of diagnosis of muscle invasive bladder cancer. Sir, Hemant sir, your thoughts on this? Or should we go?
I agree with you that from the diagnosis to the time of surgery, it should not be a delay of more than 12 weeks. Ideally, the earlier you operate, the better. But when you're giving in neoadjuvant chemo, there are 2 concerns. One is whether the operative morbidity is going to be more if you are given neoadjuvant chemotherapy. And the second concern is that what happens if the patient starts progressing during chemotherapy? Have you missed the bus for a curative treatment? So any thoughts on this, Avinash?
Sir, sorry, sir, I didn't get you. Sorry.
First, this thing is the surgical morbidity more if you are given neoadjuvant chemotherapy?
Yes.
Yes.
No, so surgical morbidity, it facilitates a resection, so it is.
Yeah, so there is no difference in the surgical morbidity, whether you're given NACT or not. Okay. And the second thing is, if there is disease progression, there is always that risk, but at the same time, if you're monitoring the patient after every cycle, then you'll catch these progressors early.
Yes.
Fine. So this is what the surgery was done. Anterior pelvic exentration was done with the lymphadenectomy. The post-op histopathology was suggestive of a YPT4A N1 disease, single node positive in the pelvic node. And coming to the last question for this subset of case 2, how do you classify lymphadenectomy for bladder cancer, and what is the impact of lymphadenectomy on survival? Avinash first, Archana second question.
The standard template will include the aortic bifurcation superiorly, inferiorly.
No, how do you classify them? What is standard? I mean, is there a way in which you classify?
Standard, extended, and super extended.
Yeah, what are the boundaries?
The standard involve the aortic bifurcation superiorly. Inferiorly will be genitofemoral now. Like circumflex iliac vein.
The proximal extent is what I'm asking. The side margin. What is extended? What is
bifurcation? Common iliac. Aortic bifurcation.
And super extended?
It's above the inferior mesenteric artery.
Above or up to?
Up to.
And does extending the field of lymphadenectomy, does it impact survival?
The LDA trial, which says that limited versus extended. There was no difference in
No correlation.
recurrence. And also, this ongoing swap trial is there.
Hemant sir, your thoughts on this?
The LEA trial had not shown any benefit. However, the meta-analysis which was done in 2019 had shown better RFS and OS, but there is a better RFS and DFS where there is no effect correlation was found between the extended template lymphadenectomy and overall survival.
Hemant sir, your thoughts on this? I think Hemant sir, I think is not available there. So the data on extended lymphadenectomy after neoadjuvant chemotherapy is a little spicious, is a little bit here and there. What really is the benefit of extended lymphadenectomy? We really don't know. Most people would tend to do extended lymphadenectomy either up to where the ureter crosses the iliac vessels or up to the bifurcation of the aorta. The role for extended, super extended up to the root of IMA, we really don't know what the benefit is. Although in our standard practice, that's what we do. 2 studies are ongoing. This walk study, like Archana said, is, we'll have to await the study for that. And there's also a study from India, which was initiated at the urology department at the All India Institute of Bhubaneswar, which is comparing standard with extended lymphadenectomy. We'll await the results of that study as well. As far as our own paper goes, it's out for publication, not yet published, but the added benefit of super extended lymphadenectomy that we do at our institute up to the root of IMA, only those patients benefited who had a solitary node in the pelvis, in the standard template area. They were the people who benefited from the extended lymphadenectomy. People who had common iliac nodes, and then if you went on and did an extra super extended lymphadenectomy, did not benefit. And I think we are completely out of time, so I will just come to the last question on this case. Is a 48-year-old gentleman, diabetic, evaluated for hematuria, underwent a CT scan abdomen pelvis. As you can see, multifocal bladder tumor. Tumor is there everywhere within the bladder. Urine cytology was negative. Metastatic workup was negative. TURBT was done. We could not resect the entire tumor because it was so huge. We resected about 70% of the tumor. The biopsy was suggestive of invasive urothelial carcinoma, high grade CA. Because we have enhanced cystoscopy, NBI routinely keep doing it. So we detected, additional lesions. CIS was present. Lamina propria invasion is seen. So it's a multifocal T1 high grade with CIS. Muscularis propria is not involved. What's the role for next treatment? Will you do a re-TURBT, try to remove everything else and give intravesical therapy or early cystectomy? What is the rationale to give early cystectomy, to do early cystectomy, and what is the benefit of early cystectomy? Archana, you can go, or Avinash, you can quickly. I think otherwise Rijan will, before he shuts me off, let's get these answers done.
Early cystectomy should be considered since the tumor is multifocal and with the presence of carcinoma in situ.
Multifocal T1 high grade CIS, fine. But why should you do early cystectomy? What is the rationale to do it? I could say that, go ahead, 70% is already done. Do a repeat TUR in about 2 to 3 weeks time, remove everything else and give BCG. So why would you want to do an early cystectomy compared to doing a re-resection, remove everything and giving BCG? What is the added benefit? Why do this? Archana? Avinash, do you have an answer, or quickly I'll give the answer and shall we conclude this session?
No, sir, no.
So we have to know that we are talking about recurrences here. And even if you go and remove all these tumors in these T1 high grade multifocal tumor, when you have a recurrence, 50% of the recurrences will be invasive recurrences, will be T2 recurrences. So 50% of them in this subset will be T2. So what is potentially curable now as a T1 disease? You go ahead and do an early cystectomy with an improvement in survival. If you wait for the recurrences to happen, 50% of them will still be T1, but 50% would have had a T2 recurrence, that is a muscle invasive recurrence. And when you do that, the survival for these 50% of these patients is automatically going to be much inferior as compared to the T1 high grade. So that is why you should contemplate doing an early cystectomy to prevent an invasive recurrence at a very near future point in time. and a dip in survival for these patients. I think with that, we can conclude the case discussion
I
here.
say one sentence.
Yes, sir. Yes, sir. Hemant, sir. Yes, sir.
I think another rationale for doing an early cystectomy is that if you look at the early cystectomy series, about 13% of them have extravascular disease at the time of cystectomy. And
Perfect,
some of
sir.
them even have nodal metastasis. So that only shows us that our current imaging techniques and the staging techniques are not optimum. And that's why an early cystectomy will help you identify these patients with a more advanced disease. That's the
Final concluding thoughts, Dr. Hemant, sir, on any of these case scenarios that we had, non-muscle invasive, muscle invasive, or early cystectomy. Any last thoughts, and then we'll hand it back to Srijan.
No, I just told you about this. Was I being heard or not?
So for a bit, for that last 1 minute when you were discussing that early cystectomy, I think we lost you, but I think we got you back again.
Okay. I think what you said is absolutely right, that to majority of these recurrences are muscle invasive, 50% at least. And that is one of the reasons why we do an early cystectomy. And if you look at the literature, there is a gross difference in survival when the cystectomy is done for T2 patients rather than T1.
Yes.
That one. Secondly, at the early cystectomy series, nearly 30%, now 1/3 of the patients have extravascular disease, and about 9% of patients have nodal metastasis. So there is a gross understaging that is involved, and that is why an early cystectomy helps.
And just to add to what Hemant sir said, and then I'll hand it over to Srijan, that whenever you do an early cystectomy, it is always mandatory to do a standard pelvic lymphadenectomy as part of the early cystectomy. For the reasons that Hemant sir said, there's about 9 to 10% risk of having nodal metastasis there. So early cystectomy doesn't mean that you just go remove the bladder and come out and do some reconstruction. You also have to do ipsilateral pelvic lymphadenectomy. Thank you, Srijan, and I think thank you for extending this time. We're completely out of time, and we hand it back to you.
Yeah. Thank you so much, Anand sir and Hemant sir. Before we actually move on for the expert talk, I would invite comments from both examiners as to how our final year residents fared in their mock examination, and strictly as per your clinical exam per se, in their knowledge as well as their presentation style. I'll hear it from Dr. Anand first and later from Hemant sir.
Yeah, I think the students did quite well. My impression was that both the candidates knew quite a bit. I mean, they were really there. They were really spot on, especially the Vesper trial and all that. You knew the latest advances that are there. But the one thing that I saw that you were not really good at is, the recent advances. Always remember, this is something that I keep telling all my students as well. The recent advances and the latest trial, the latest numbers, these are things that you are usually very good at, and these are things that you will know very well. And the examiner also knows that you know the Vesper trial, so he will not try to trip you there. The things that you will be deficient at is the etiology section, is the pathology section. We did not go into the molecular oncology classification or all those things. Like a simple thing like smoking. What is the risk factor for smoking? You can't say high and low, that is at a much lower level. So the thing that you should be strong at are things that come much before management, the etiology section, the epidemiology section, and those are things that you should be very good at. And the number, you should have it like with you, like spot on. It's very, very easy to get tripped there because that's where the Viva starts. And if you trip there, then, anywhere you trip, it's always difficult to make a big comeback. The Vesper trial or anything that you said is commendable. I congratulate you on knowing all that, but that comes at the very end if you don't trip anywhere else, and that's a long way till there. So get your basics right, get the numbers right, and understand that this is an MCH exam, not an MBBS or an MS exam. High and low does not work here.
Perfect, Dr. Anand. Hemant sir.
I think what you said is absolutely right, that you need to be very specific when you are at the MCH level or DNB level. You need to be. So the exact figures you should know. I mean, generally everybody knows that NSAT works and this, but what is the exact benefit that one should know. Secondly, this is not a theory exam; it's a practical exam. So I think you need to spend some more time in uro-oncology theaters to see what exactly, or in the OPDs to see how these patients are actually managed practically. So I think that is something which I thought was a little lacking, but otherwise both of them did very well.
Excellent. Thank you so much, examiners. We move on to the next segment of this webinar, which would be the expert talk by Dr. Hemant. Sir, we request you to kindly share your screen, and we are all yours.
Can you see? Hello?
Yeah, it's visible, sir. Full screen, yeah.
See, a lot of these things which I'm going to say have already been covered in the discussion, so I'm just going to gloss over some of those things. See, bladder cancer is the second commonest urological cancer in India. It's a disease of the elderly, usually more than 65 years of age, with male predominance, 8:1. It's not one disease, it's a spectrum of disease, on one end of which are those indolent non-muscle invasive cancers, where the aim of treatment is to preserve the patient's bladder without compromising survival. And at the other end, muscle invasive cancers, which have an aggressive biological behavior. No, it's an unforgiving disease, and you've got to do everything right every step of the way to achieve optimum outcomes. Majority of cancers at diagnosis are non-muscle invasive. They used to be called superficial, but they are not superficial. They are invasive, but non-muscle invasive. 25% are muscle invasive and 5% are metastatic, majority being urothelial. Now, as we know, majority of these patients present with painless gross total hematuria, which may be episodic or which may be persistent in later stages. Actually, those who have only microscopic hematuria have probably a much better biological behavior and are diagnosed and do better than those who have a gross hematuria. Ultrasound is usually an initial screening investigation, but if you have a patient with hematuria, only an ultrasound is not good enough. It will identify a lot of a wide range of abnormalities in the urinary tract, but cannot rule out all potential causes. So basically, disease in the upper tracts cannot be ruled out by doing just an ultrasound, and that is why you need to do a CT scan or a CT urography, which is the gold standard in patients with hematuria. It will not only identify the site of the disease, but it will also delineate the tumor characteristics. Now, in likely muscle invasive disease, the idea is to identify the extent of disease locally and also at the nodal areas. Unfortunately, CT scan is not the best modality to look at the nodes. We still don't have an optimum modality. But in these cases, sometimes you can do a PET CT. Now, PET CT is not for local staging within the bladder, but it is for extravesical disease. And if you want to rule out nodal metastasis or you want to rule out distant metastasis in advanced cases, then PET CT should be done. CT urography is not routinely necessary, but only if the patient has a large, broad-based, solid, multiple or high-risk tumors or trigonal tumors, or there is positive urine cytology, then one should be doing CT urography. What about multiparametric MRI? There's something called WIRADS, like you have WIRADS for breast, etc. And this has also been investigated in a lot of studies. And this basically can very clearly show you whether the muscle is, the tumor is muscle invasive or non-muscle invasive. This has been validated in numerous studies and is being recommended for NCCN for sessile or high-grade tumors and by NICE when the radical treatment is contemplated. Actually, this can obviate the need for even for a second TUR. Now, this needs a lot of expertise and there is a learning curve associated, but if somebody is well trained in MP-MRI, then it can give you can see a very good sensitivity and specificity with a pooled sensitivity of 0.83. Pooled specificity of 0.9, which is extremely good. Now, we've already talked about urine cytology, that very high sensitivity in high-grade tumors, not so much in low-grade tumors. Especially in patients who have hematuria but no lesion seen on ultrasound, one should do cytology. The real value is in papillary low-grade tumors on cystoscopy, those who have positive cytology, one needs to investigate by doing multiple random biopsies from the bladder and doing biopsies from the prostatic urethra and also looking at the upper tracts. So most of the guidelines with a strong recommendation say that you use voided urine cytology as an adjunct to cystoscopy to detect high-grade tumors. Urinary molecular marker tests, there are various tests which are available, but none has been accepted in routine practice by any clinical guidelines, either for diagnosis or for follow-up. So the most important investigation is, of course, a cystoscopy, where you can not only see the tumor, the number of tumors, the type of tumors in the papillary tumor. Now, this is a broad-based, comparatively solid tumor. So this is likely to be a low-grade, low-risk tumor. This is also low-grade, but likely to be an intermediate risk with larger tumors, multiple tumors, and this is likely to be either a lamina propria invasion or likely to be a muscle-invasive tumor. So one needs to really have this kind of a diagram and map out all the tumors properly. And of course, at the same time, one can do a TUR, which is the most crucial procedure for diagnosis and to remove all visible tumors. Now, something which is improperly done in a majority of patients, even by urologists, by uro-oncologists, one needs to do TUR extremely meticulously. One not only needs to go down to the muscle, but one also needs to go all around the tumor and take muscle all around, because you can see it doesn't always go down, doesn't always go down like this. It can go in the form of multiple tentacles, and that's why you need to go right around the tumor and you need to take the entire depth. You should not use coagulation current here because you will get a lot of artifacts, and this deeper portion should always be separately sent to the pathologist. Now, whether you do a fragmented resection or you do an R-block resection doesn't really matter. R-block resection will give you a better pathological review. Only thing is R-block resection is not possible in large tumors or solid tumors where there is a higher chance of getting muscle invasion. So it's possible when it is not really necessary, and it's necessary whenever it is necessary, it is not possible. We have already talked about NBI and fluorescence cystoscopy. It does reduce long and short-term recurrences, but there is no impact on the progression rate. Bimanual examination after the TUR is extremely important. If there is a mass that you feel even after doing a TUR, that means that patient has extravesical disease. So this should never be missed. Now, random mucosal biopsies from bladder or prostatic urethra. Again, we've spoken about this. From suspicious areas like reddish velvety areas which are suggestive of CIS, one should take. But even when the cytology is positive, but you find a normal looking mucosa, one should take biopsies from all walls of bladder, preferably with the use of photodynamic diagnosis. Prostatic urethral biopsies, again, if there is a tumor in the bladder neck, CIS in bladder, positive urine cytology without a tumor in the bladder, or if prostatic urethral abnormalities are visible, then one should take from the precollicular areas at 5 and 7 o'clock positions. And positive prostatic urethral biopsy does not preclude a neobladder formation. You still do a intraoperative frozen section confirmation of negative margin at the level of transection. Now, second transurethral resection is to remove all the residual disease and to correct the understaging. And you can see that there is a very large meta-analysis of more than 8,000 patients, which showed that 51% patients had persistent and 8% upstaging in T1 patients. Another meta-analysis showed there is a 58% persistence and 11% upstaging, even in patients with detrusor muscle present in the initial specimen. So that goes to show that even if there is muscle that you see in the specimen, but if the patient is high risk, one should do a second TUR. Now, this residual disease is usually confined to the site of previous resection only. It's recommended 2 to 6 weeks after the initial resection and can increase the RFS, PFS, and OS. OS, especially in patients where there was muscle that was seen. It improves outcomes of treatment like BCG. Now, what a second TUR does, it identifies the true T1s and separates them from T2 lesions. So in T1 lesions, the true T1 lesions, if you give BCG, obviously the response rates are going to be better. And T2 patients can undergo cystectomy at a much earlier stage than what normally they would have had if they had not had a second TUR. So again, it improves outcomes of T2 patients. So it improves outcomes of treatment and of course provides prognostic information. What do you ask your pathologist for? Basically, tumor histology, urothelial, non-urothelial, the tumor grade, which is the most important factor for that impacts disease or stage progression to muscle invasion. And if you look at the current grading that we do, it's papilloma, then we have papillary urothelial neoplasm of low malignant potential, low grade and high grade. This is how the grading is done nowadays. It's not grade 1, grade 2 and grade 3. Then presence of detrusor muscle, so adequacy, then staging and substaging of tumor, whether it's the involvement of lamina propria, muscle, muscularis, necrosis, etc. This is again very important, presence of CIS and lymphovascular invasion. And what has been reported more and more commonly in recent times is the variant histology, which is either small cell, sarcomatoid, lymphoepithelioma type, nested, micropapillary. There are so many varieties which basically have a much more aggressive biological behavior. They are more likely to be diagnosed in advanced stages, and these, even if they are diagnosed in early stages, should have a radical cystectomy and not any intravascular therapy. So this is extremely important. We also discussed about the risk stratification. Now there are about 6 factors which are looked at in the EORTC classification, and then these will quantify the probability of recurrence at 1 year and 5 years. Similarly, probability of progression at 1 year and 5 years. So based on this, you can decide whether the patient needs intravesical therapy or whether he should have an early cystectomy. Then coming to the single immediate post-op installation of chemotherapy. Now, we talked about the drugs that are used, most commonly used is mitomycin, and also we can use doxorubicin or epirubicin. But see the impact, 39% reduction in the odds of recurrence, extremely significant. We have 14% absolute reduction in recurrence and extremely low incidence of side effects. So it's very safe. Predominantly, it helps in low-grade tumors and low intermediate risk patients. Only those with a recurrence rate of less than or equal to 1 per year, or those with EORTC recurrence score of less than 5, they benefit from this single installation. If the EORTC recurrence score is more than 5, there is no benefit that is accrued by giving a single installation. It should be given within 24 hours, ideally within 6 hours of surgery. It should be kept for at least about an hour. We need to really monitor the patient in that 1 hour. The precautions that one needs to take are basically that you have to be very sure that there is no perforation or even a micro perforation, there is no bleeding. And in these patients, one should not do installation of mitomycin. Coming to the intravesical therapy for low-risk patients, after one immediate installation of intravesical therapy, no further therapy. For intermediate risk, you can either give 1 year of BCG or 1 year of mitomycin. Okay, so it's induction plus maintenance at 3, 6, and 12 months. And in high-risk patients, of course, you have to give only BCG here. No chemotherapy really works. No chemotherapy agent can reduce the risk of progression to muscle invasion, but BCG can do that, and that's why BCG is the one that is used for high-risk patients. And here the maintenance therapy needs to go on for about 3 years. Now, if the patient is unwilling to do that or unwilling to take the risk of recurrence, then you can discuss immediate radical cystectomy with these patients. But if it's a very high-risk patient, then of course, these patients should have radical cystectomy upfront. But if they refuse or are unfit for radical cystectomy, only then BCG should be considered. Now, this is what I was telling you about optimized mitomycin C. that adapting urinary pH, decreasing urinary excretion, buffering intravesical solution, 1 hour installation, and increased drug concentration. These are the 5 measures which are used. And there is a randomized trial which showed that there is a longer median time to recurrence and greater recurrence rate fraction if you use an optimized schedule. This is by all in 2001. However, these device-assisted therapies for mitomycin installation have not shown any benefit. Now, what is the dose that can be used? Again, there is a randomized trial by Cueto, the Spanish cooperative group, and here they use 1/3 dose versus the standard dose. They found that there is a significant decrease in the side effects, but the severe side effects were similar. Now, multifocal and high-grade lesions have better results with full dose BCG, but in other, like the intermediate risk patients, probably would have no difference whether you use a low dose or a high dose. Now here in India also we have had a randomized trial, however small, for 80 milligrams versus 120 milligrams, and I think there is not much difference in survival except in high-risk patients. Now, do you really need to use maintenance? Well, intravesical BCG can reduce the risk of progression only in patients only where maintenance therapy was used. You can see that if maintenance therapy was not used, then there is no difference in outcome. So it is only effective in trials with maintenance therapy used, where it reduced the risk of progression by 37%. So, and the commonest maintenance regimen that we use is the SWOG regimen or the RAM regimen, where at 10 years follow-up recurrence rate reduced from 52 to 25%, RFS increased from 30 to 48%, and OS increased from 51 to 57%. So there is an OS benefit which is also associated with this particular regimen of maintenance BCG. Now here most patients, as expected, did not complete therapy. So what they postulated was there's probably an early benefit and probably 1 year may be as good as 3 years. But a randomized trial comparing 1 year maintenance versus 3 years maintenance showed that 1 year was not as good as 3 years. Now, for very high risk patients, of course, those who are at the highest risk of progression, these are the patients, multiple or large T1 high-grade tumors, T1 high-grade tumors with concurrent CIS, T1 high-grade with CIS in prostatic urethra, variant histology and lymphovascular invasion. All these patients should have an upfront cystectomy and not BCG. I think BCG failure we have already spoken about. Basically, BCG unresponsive patients, they should have an early cystectomy, while late BCG relapsing patients is more than 6 months or CIS more than 12 months after last BCG exposure. Here you can have bladder preserving strategies also, or a radical cystectomy. Now, which are the bladder preserving strategies? So basically, early cystectomy in unresponsive patients, I think Dr. Raja has very clearly showed us that if you do a cystectomy when there is no muscle invasion, then the survival rates are very high. But as soon as they become T2 or T3, then even an early cystectomy doesn't give you best of results. So basically, there are multiple reports in the literature which show survival benefit with early cystectomy. What about the bladder sparing approaches? That means the patient has responded to your intravesical BCG and then relapsed. So here you can use a second course of intravesical BCG, about 27 to 50% would respond. Or you can use intravesical immunotherapy, like BCG with checkpoint inhibitors or immune stimulating agents like interferon. They have been used. But what is most commonly used nowadays is intravesical chemotherapy, a combination of gemcitabine and docetaxel, which probably gives the best results in terms of relapse-free survival, 60% at 1 year and 46% at 2 years. Here you can use device-assisted therapies like microwave or HIVEC. Immunotherapy with checkpoint inhibitors like pembrolizumab that we again discussed during our discussion. Again, an excellent alternative. And of course, there are various gene and novel therapies that are only available. What if the patient does not tolerate BCG? Do you give up on those patients and advise cystectomy? Well, there are certain measures which we can use. We can reduce the dose, increase the instillation interval, maybe not do it weekly, do it 2 weekly, reduce the dwell time from 2 hours to maybe 45 minutes, 1 hour. Giving a single dose of ofloxacin at 6 and 18 hours after the instillation brings down the toxicity very, very significantly. And this I use in my practice and use tremendous results. AKT, only in those patients who have a severe bladder toxicity or a systemic toxicity, you can use AKT. We have already spoken about this. What are a follow-up schedule for low-risk patients? As I said, 3 months after the TUR, then 9 months after that, and then annually. But for high-risk patients, of course, every 3 months for 2 years, then every 6 months up to 5 years, and annually thereafter. This is like for all other cancers. And you consider cytology and an ultrasound to be done at each or at every 3 months. Now, upper tract imaging in low-risk patients is not necessary, but in high-risk patients, then one should, when the risk of upper tract recurrence is about 18%, one should be doing an annual upper tract, annual CT scan for the upper tracts. Now, muscle-invasive bladder cancer, these are the options of treatment that we have. And of course, radical cystectomy with lymphadenectomy is the standard of care. Use best results in terms of local control and survival. These are some of the large series. But despite an adequate radical cystectomy, nearly 50% patients relapse and die of their disease. And one needs to do an extended template lymphadenectomy as an integral part of the treatment, because the incidence of lymph node metastasis is about 24 to 28%. So normally what I do is do a routine lymphadenectomy after the aortic bifurcation. I go above the level of ureteric crossing basically because there is nearly 15 to 20% of patients who will have common iliac and the medial inter-iliac lymph nodes positive as an isolated lymph node metastasis, bypassing these, and therefore if you go up to the aortic bifurcation in all patients, you can certainly sample at least, or you can certainly get more than 90% of the total nodal burden. When these nodes are negative, the upper nodes are very, very, very rarely positive. But if these nodes are positive, then one can go up to the level of inferior mesenteric artery. So lymph node yield and lymph node positivity increase significantly. There is an improved survival reported with increased number of lymph nodes, minimum 14 nodes per site. There is a phase 3 trial, lead trial, extended versus standard. They found no difference in survival, but a meta-analysis of 12 studies showed an improved survival with an extended lymph node dissection. Although these are not from randomized trials, there are multiple large trials which have shown that there is a survival benefit with extended lymph node dissection, and these are all p-values which are highly significant. What about minimal access radical cystectomy? Well, there are 2 trials. One is the RAZOR trial and the Farage trial, which compared robotic versus open radical cystectomy, and they found that surgical approach was not a predictor of any outcome. 2-year RFS, which is the intermediate term oncological outcome, time to recurrence, positive surgical margins rates, major adverse events, and quality of life was similar in the 2 groups. But length of hospital stay, blood loss was lesser in the minimal access group, but operative time was longer and increased cost. What was very disturbing were the atypical metastasis, like peritoneal metastasis, which was seen more commonly with the robotic approach. And this has been seen in many cancers, and that is why the idea here is to avoid spillage during surgery. So with that, so surgeon experience and institutional volume are the key factors. There is a definite learning curve, and if basically the patient should be informed about the advantages, disadvantages of both procedures, and the surgeon should be honest enough to say that, okay, the best results in my hands are with open technique or with robotic technique, and then take the decision. So this is what even the EUA says, EAU, that inform the patient and select experienced centers, not specific techniques, both for RARC and ORC. In women, is it really necessary to remove the GI tract? Well, not in all patients. In select patients, wherein there is involvement of bladder cancer unlikely, then neobladder can, especially if the neobladder is considered in a female patient, then one can certainly preserve the gynae tract. Actually, it gives a better support to the neobladder. But if there are deeply invasive posterior tumors, then one should not be doing gynae tract preserving surgery. Lastly, coming to NACT, what is the evidence of benefit? The updated analysis with follow-up of 8 years showed that there is a 16% reduction in mortality risk, improvement in 10-year survival, benefit with regards to distant metastasis, and the meta-analysis showed there is an 8% absolute survival improvement at 5 years with number needed to treat 12.5, and this benefit is seen across all stages, even T2 to T4. However, there are no predictors today to select patients who are likely to benefit from NAC, and therefore one needs to monitor these patients when the patients are taking neoadjuvant chemo. Now, the randomized trial evidence is for MVAC and CMV, but of course, dose-dense MVAC also can be used. But majority of medical oncologists still use GemCis. And why is that? That is basically because the percentage of P0 or T0 that you see in the cystectomy specimens after MVAC or after GemCis is the same. So that is why even GemCis is used by majority of medical oncologists. So NACT followed by definitive local therapy should be considered standard for muscle-invasive bladder cancer. Now there are two concerns about NACT. Does it affect surgical mobility? There is no difference. And does it delay cystectomy? Again, there is no evidence that delayed surgery due to neoadjuvant chemotherapy has a negative impact on survival, and therefore NACT should be considered standard in all patients. You will be surprised that only about 19% of patients worldwide receive neoadjuvant chemotherapy. So that's something that needs to be corrected. What about adjuvant chemotherapy or immunotherapy? Again, there are 9 trials. None of the trials have individually shown a benefit. There is a trend towards OS benefit in this meta-analysis, but there's a definite PFS benefit. And the similar, this was seen in a retrospective cohort analysis, a large one. But if you look at the level 1 evidence, that is only in a meta-analysis, not in a randomized controlled trial. So what are the recommendations? There's a strong recommendation that one should offer cisplatin-based combination therapy to patients with PT3, P4 or PN plus disease if no neoadjuvant chemotherapy has been given. And if the patient has already received chemotherapy or is not fit for chemotherapy, one can discuss adjuvant immunotherapy option with nivolumab, atezolizumab, or with pembrolizumab in selected patients with PT3, P4, PN1. Trimodality treatment for bladder preservation. Is there, do you always have to remove the bladder in case of muscle invasion? Not necessary. There is a small subset of patients who can have a bladder preservation with what is called trimodality treatment. It's a combination of maximal TUR, chemotherapy, and external beam radiation therapy. There are no trials, randomized trials of trimodality treatment versus radical cystectomy, so there has to be a selection. Now, only radiation is not adequate. One needs to give chemoradiation, and maximal TUR is of great prognostic importance. If patient, the bigger the residual disease after TUR, the survival rates are equally poor. So one needs to do a maximal TUR before you're putting this patient for chemoradiation therapy. So it requires a multidisciplinary consultation. And if you look at the 5-10 years survival with an intact bladder, about 40% of them will have an intact bladder at the end of 5 years. Now, there are 2 types of approaches. One is called a split course, where you reassess at a midpoint of the radiation therapy and then decide whether one should go ahead with cystectomy or consolidation. But what is now used, which is much more common, is called a full course. And here you complete the chemoradiation therapy and then assess if there is no residual tumor, with the patient surveillance, if the patient has residual tumor, cystectomy. This is the most important step. Salvage cystectomy is extremely important if you are going to have good success with this approach. So if the patient does not have a CR at the end of TUR plus a full dose CRP, one should do a prompt cystectomy. And only these patients are eligible. Only about 9 to 15% of patients are eligible. T2 or early T3A tumors, unifocal tumors less than 5 centimeter, absence of associated diffuse CIS, absence of hydronephrosis, no mass on EUA, ability to resect tumor completely, no prior pelvic RT, and no contraindication to chemotherapy. Apart from this, what is important is the compliance to treatment. So one needs to have a well-informed, highly motivated patient who understands the whole treatment approach, who understands the need for salvage cystectomy if the response is less than complete. Well, I think I've discussed most of the aspects of bladder cancer, apart from metastatic cancer. Thank you so much. Thank you very much.
Thank you so much, Hemant sir, for covering almost 2 topics actually in one presentation. What I'll do is I'll quickly go on to the last segment for today, which is Q&A for the experts. So what we do here is we take the questions from the Q&A, the chat, and from YouTube, and I consolidate them into what are the most common questions and what in which line they are. So what I'll be doing is I'll be addressing these to specific examiners, but obviously we welcome comments from others also. So the first question to Dr. Anand is, what are the real world indications for PET-CT in bladder cancer for you? You're muted, sir.
I've unmuted. So the contemporary in today's day and age, for me, I would do a PET-CT scan in a non-metastatic setting only if I have some indeterminate nodules in the lung or something in the bones that I am not able to characterize one way or the other. That's when I would do a PET-CT scan. I mean, to characterize atypical sites of metastasis, whether it's meta or not, for nothing else would I do it.
Correct.
But Dr. Hemant also said something about the extravesical disease and the nodes. That's also completely acceptable. But I don't use it for that.
Hemant sir, anything else on that?
PET-CT, I think there is a definite role for PET-CT if the patient can afford that and if it's available. If it's not available, then at least I would do a CT scan of the abdomen, pelvis, and chest. And if the patient has any symptoms, then a bone scan. But a PET scan, I think, is very good to differentiate when there are indeterminate lymph nodes.
Right. Our second question is urinary conduits and the anastomosis techniques. Do experts have a single technique of choice, or is it more case specific? Hemant sir.
Well, whenever you're doing a conduit, whether you do a ideal conduit or a colonic conduit, there is not much difference. But for the ease of doing the surgery as well as for putting the bag, the right-sided or ideal conduits are found to be much better. As far as the ureteric anastomosis goes, that every person has a different technique of doing. Now, what I do is if there are small ureters or normal size ureters, what I usually do is direct reimplantation after a very wide spatulation, so there is no chance of any ureteric stenosis in future. But if they are very large ureters, sometimes I do a Wallace technique where I join both the ureters and join them to the end of the conduit rather than the end to side anastomosis, which I would normally do. So these are, and I always take interrupted sutures, I don't take continuous. Of course, there is nothing good or bad about continuous or intermittent. In my hands, I find the best results with intermittent, that's why I do. But there are different techniques which are more surgeon specific than case specific.
Perfect, sir. Anand sir?
I do Bricker always and interrupted always. So,
yeah. Our third question to Dr. Anand. So, sir talked about organ preservation for MIBC. How is it applicable in Indian setting, and what is the maximal TUR that these protocols mention? So,
when you say, so I'll take the questions in the reverse way. What is the maximal TUR? Removing of all gross macroscopically visible disease when you do a transurethral resection is what is called as macroscopic, is called as maximal TUR. We know that is muscle invasive disease, so you might probably not remove the microscopic disease, but all macroscopically gross visible disease, if you're able to remove all of that, that is called as maximal TUR. And organ preservation rates for MIBC, I think the organ, if I have to sum it up in 2 lines, the organ preservation MIBC can be a lot more than what it is today. That's number one. And probably one of the reasons that organ preservation is really not taken up in a very big way, apart from a few academic centers, until the patient wishes for it, is that most of the patients comes to the surgeons, whether to the urologist or to the uro-oncologist. There's there's a little hesitancy to refer for other therapies. That's number one. Second, there is strict selection criteria. You need to have tumor less than this size, no concomitant CIS, so on and so forth. Patient should be eligible for maximum TOR, should be eligible to get neoadjuvant chemo radiation, should be eligible for chemotherapy. The number of patients that fit into this criteria are not that very great. So that's why organ preservation is not taken up. But yes, the number of patients that are eligible are probably a lot more than are being offered.
I think we started organ preservation way back in 90s, and we published our results twice. One in 1996, one is 2010. And about 40 to 45% of patients are alive with an intact bladder at 5 years. Now, recently, Dr. Vedant Murthy at Tata, he uses the plan of the day adaptive radiation therapy, and he claims and he's shown that nearly 70% of properly selected patients can have a good organ preservation. So, as Dr. Raja rightly said, with better techniques of radiation and with better chemotherapy drugs, probably we'll see more and more of organ preservation in future.
Perfectly said, sir. And I think one of the reasons that organ preservation is not taken up is, apart from, focus centers where there are focused people doing it, in most of the other centers, if you see over the lifetime of a patient, if 100 patients get bladder preservation, over a lifetime of a patient, whether for recurrences or for complications, only 50% of them will retain their bladders. Yes. 50% of them will lose their bladder either for a recurrence or for a complications. Right. So 50% of the patients end up getting 2 modalities of treatment. And as we already know, doing a cystectomy after radiation is not very easy. So that's probably one of the reasons that it's not taken up very well.
Our last question is, for dome invasive cancers, is partial cystectomy an acceptable choice? Hemant sir.
Absolutely. But there are 2 things that one needs to see. One is that you get an adequate margin all around. So for a very large tumor, obviously you won't do. But for smaller tumors, I would normally take a margin of at least 2 to 2.5 centimeters all around. Take multiple random biopsies from the rest of the bladder just to make sure that there is no carcinoma in situ or some tumors that were missing. And one can definitely do a partial cystectomy. Now, again, we published our results in around 2000, and about 16 patients were done. But today, with new bladders, which can be so easily done, there is a trend towards doing a radical cystectomy rather than a partial cystectomy, which requires an lifelong follow-up with cystoscopies. It's much better to do a radical cystectomy and do a new bladder. Unless the tumor is really small, then one is very reluctant to do a complete cystectomy.
Your thoughts?
I completely agree. The only thing that I'll disagree with, not disagree, the only thing that we do differently is that we have narrowband imaging, which we routinely use. We published our data on the narrowband imaging as well. So instead of doing the multiple random biopsies, we just use the NBI to see for additional lesions. If there's CIS or something like that, then this is not a procedure of choice. But everything else is perfectly said by Dr. Hemant.
So thank you so much, Hemant sir and Anand sir, for the last couple of hours. And I'm sure many residents, even in the future, will be viewing this and referring to this discussion today and the expert talk and take it as a basis from where they can read up more and learn more about the subject. Dr. Rajgovind sir, are you there, sir?
Yeah, can you hear me?
Yeah, perfect, sir. I invite Rajgovind sir finally to kindly address our assembly today.
Oh, wonderful session. Both the residents, Avinash and Archana, have done extremely well, and I will compliment them for the preparation. Just a word of caution. They need to learn the practical aspects, not only theory, because you'll have to face many types of bowlers. There'll be spinners, there'll be fast bowlers. So the examiners will be all sorts of examiners. It's not necessary, like both the examiners have said, that you'll be taken to just the moleculars and the genetics, but you might be asked the basics questions also. Many of the residents, I ask, if you don't have xylocaine jelly, can you use ointment? They cannot answer that. So we need to learn the basics and the practical aspects. Dr. Hemant and Dr. Raja have done wonderfully well. They are great teachers and have examined, at the same time have taught the subject very well. Their comments on stress on basics and inclusion of more bedside situations is well taken. And so on behalf of IASO President, Dr. P.K. Das, Secretary, Dr. Chandramohan, the IASO Academic Council, Dr. Sanjeev Mishra, Arnab, and myself, I thank all the participants, examiners, and experts for their time and effort. I also thank Dr. Subramanian Rao, the convener of the IASO Academic Master Series, and Dr. Srijan, who has done a wonderful coordination. Thank you very much.
Thank you so much.
Thanks.
Thank you so much, everyone. This will be all from us tonight. We wish you all very well, and we'll see you in a fortnight's time, same time, Tuesday, 7 p.m. Thank you and good night.
Thanks. Thanks, everyone. Thanks, Srijan. Thank you, Sharma sir. Thank you, Hemant sir. Thanks, everyone.
Thank you.
Thank you, everybody. Thank you.